Hello everyone, this is Surgical Clerk Ramasamy Muthu from Cebu Institute of Medicine. Today, in this video, we'll see how to perform endotracheal intubation using improvised materials. We are presented with a case of a 43-year-old ASA1 female who is scheduled to undergo elective thyroidectomy. I was tasked with performing endotracheal intubation on this patient under the supervision of an anesthesiologist. Before we proceed, it is important that we observe proper hand hygiene and wear appropriate personal protective equipments. Once done, the first step is to evaluate the patient. Assess the patient for a possibility of difficult intubation. We can use the mnemonic lemon to remember its components. Look externally for any facial or neck deformities. Next, evaluate the 3-3-2 rule. 3 finger breaths should fit the mouth opening, 3 finger breaths from the tip of the mentum to the hyoid bone, and 2 finger breaths from the floor of the mouth to the thyroid cartilage. Check for the Malampati classification of the patient. Class 3 and 4 suggest possible difficulty during intubation. Check for obstruction in the oral cavity and the neck. Lastly, check for neck mobility. Step 2. Materials needed. The materials needed can be remembered using the mnemonic MAIDS. M stands for monitor, pertaining to cardiac monitor and pulse oximeter. A for airway, pertaining to bag valve mask, laryngoscope, endotracheal tube, and stethoscope. For our patient, we use a laryngoscope with Macintosh blade and an ET tube with an internal diameter of 7 to 7.5 mm. Make sure your laryngoscope has a functioning light source. Also make sure your ET tube cuff is patent by inflating air using a syringe. I stands for IV access and fluids, while your D stands for drugs to be used, while S stands for suction apparatus. The materials can also be remembered using this other mnemonic, SALT PS. S for suction, A for airway, L for laryngoscope blade, T for tubes, P for plaster, and S for stethoscope. Step 3. Positioning. Position the patient in a sniffing position using a towel or a pillow under the head, extending the neck to obtain a good line of vision on the oropharyngeal axis. Suction secretions that may obstruct the patient's airway. Perform chin lift jaw thrust maneuvers to displace the tongue anteriorly. Step 4. Pre-oxygenation. Pre-oxygenate the patient for 3 to 5 minutes using a bag valve mask connected to a 100% oxygen supply. Hold the mask with the thumb and the index finger forming a C grip around the mask, pushing it down, while the other 3 fingers are placed under the mandible, pushing it up. This forms the CE grip. Step 5. Intubation. Hold the laryngoscope with your left hand and insert the blade in an anterior-inferior direction along the right corner of the mouth and sweep the tongue to the left. Advance the tip of the laryngoscopic blade till the glottic opening is visualized. Wrist motion must be avoided and the maxillary teeth should not be used as the leverage to avoid damage. Hold the ET tube in your right hand with a pencil grip. Insert the ET tube through the right corner of the mouth towards the glottic opening. Advance it further until the cuff is about 3 to 4 cm beyond the vocal cords. Remove the laryngoscope. Secure the placement of ET tube by inflating cuff with 10 cc of air using a syringe. Once done, the stylet can be removed. Attach the bag valve mask and auscultate the lungs and the epigastrium to check for proper placement. If correctly placed, breath sound should be equal and there should be chest rise with no gurgling sounds in the epigastrium. In our case scenario, after intubation, the breath sounds was heard louder in the right than the left. This suggests a right endobronchial intubation. To correct this, deflate the cuff, pull back the ET tube by 1 cm, inflate the cuff again, and then connect to a bag valve mask. Then auscultate to check if the breath sounds are equally heard. Repeat the steps as needed till equal breath sounds are heard. In this patient, equal breath sounds is appreciated. Right endobronchial intubation is common as the right bronchus is wider, shorter, and has a more vertical course. After ensuring proper ET tube placement, anchor the tube to the right side of the mouth using a plaster. A chest X-ray may further be ordered to evaluate for proper ET tube placement. Thank you for watching. Until next time, it's your favorite senior clerk Muthu signing off.